Hi, everyone. Thanks for joining. I can see people are slowly starting to trickle in from online. So thank you for joining us for the 2022 Open Summit. Just going to let a few more people in, and I'll be passing it over to Lisa Dolovich, who will get us going for the day.
Great, and thanks, Annalise. It looks like your slides are working now.
All is well now.
Okay, great. Good.
Perfect. Okay, so I think we're good to get started. Lisa, I'll turn it over to you and just let people in as more people join us.
Yeah, thanks so much. It's great to see so many familiar names and guests all on the tiles. So looking forward to our interactions this afternoon, at least for Toronto, Ontario time. I'm Lisa Dolovich. I'm a professor and dean at Leslie Down Faculty of Pharmacy, but I'm here to welcome you to the first session of the 2022 Ontario Pharmacy Evidence Network Summit. And we're so pleased on behalf of Open and the Center for Practice Excellence at U of T and the University of Waterloo School of Pharmacy to just have everyone here for this session and our subsequent sessions to really share new research and new practice and policy and education insights related to pharmacy practice and medication management. Because it's really great to think about the opportunities for us to come together and learn from each other and also catch up with each other. And we hope that we've developed a program where we can do that over the two sessions that we're going to hold in March and the two that we're going to hold in May. I'm going to just say some remarks. I'm going to turn it over to Annalise Mathers, who works with us and has been doing an incredible job. So I'll take this time to say thank you so much, Annalise, for all you've done to coordinate this and the future sessions. It's really provided a great foundation for us to be able to have this event today. But I'll ask you to move to the next slide so that I can just do a land acknowledgement, a territorial acknowledgement, and really wanting to center us and start us off with this thinking, especially with just all that has been going on. I want to acknowledge that I'm on the traditional territory of the many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and that this land continues to be home to diverse First Nations, Inuit, and Métis people. We are all coming to this event from different places, and so with that, I'd like to invite you to really provide your own acknowledgement in your own way of the ancestry of the land and commitments made to peoples from where you are, so that you can find meaning in the consideration of that over this event. So thank you so much. Annalise, if you can go to the next slide, please. As I said, we're really pleased on behalf of Open to have everybody here. Open has been in existence since 2013, and it is a team of researchers working together across Ontario and well beyond with our collaborators to really look at the quality outcomes and value of medication management services that pharmacists and other healthcare providers deliver. We really, I think, are increasingly considering health and well-being, and what is the value of pharmacy and other health disciplines focusing on the best use of medicines for people to live their best lives. We focus on knowledge translation, building capacity, and thinking about how to address vulnerable populations in many places, including Ontario. And we've had different iterations of Open, but I think this summit is really a cornerstone for us to bring our community together, especially as we've had less opportunity to do that in the last while. We are virtual today. We hope that our next set of summits in future will be in person, and looking forward to opportunities that anybody might have to how this community can come together. Next slide, please. We are also co-hosted today from the Center for Practice Excellence, which is at the Leslie Down Faculty of Pharmacy. And the center does generate and utilize leading edge medication management research and innovation to drive educational programs and practice that can revolutionize patient care. Again, it's an overlapping network, and we are really proud of the fact that we're we are able to co-host on behalf of Open through the center today. So thank you. Next slide, please, Annalise. We are super excited about the program for today, but for all of the days. We tried to think carefully about what kind of timing and amount of time would be good to bring people together. And so we have come up with 4 2-hour blocks of time, 2 in March and 2 in May. Each of the blocks will sort of focus on a theme, really driven by the abstracts that were submitted and therefore grouped together in ways that we thought would be really helpful, and started off on each day with a fabulous plenary speaker who can help us set the tone and help give us some broader perspectives to think about. And so today we are really delighted to thinking about using research to improve pharmacy education and continuing professional development. But I do encourage you to look at the program's plan for March 16th, May 4th, and May 18th, and see how you can participate on those days, and also to propagate the information about the sessions through your own networks and see who else may wish to participate in these sessions. We're also really pleased that we've had abstract submissions from a variety of organizations and institutions across Canada and worldwide. It's great to get different perspectives, and that really enriches our conversation. Next slide, please, Annalise. Wanting to let people know that the event will be audio and video recorded, and that we will post the recordings on our website shortly. We also have the opportunity to have a question and answer period. So for each presentation, please do feel free to use the chat box feature in the Zoom, and then you can provide any questions or comments that way, and we'll do our best to figure out how those questions and comments can be addressed during the time of the presentations, or of course can be forwarded to the presenters after the presentation so that they can respond in turn to anything that was raised. Next slide. So again, the aim of our summit is to disseminate and share knowledge that is generated through research. We do know that research is really always carefully developed, and that at some times participants may be sharing research that's still in progress, and they may, we really are grateful that people are willing to come at times to the summit in an early stage. It really helps us see the thinking and the work that's emerging in the areas of presentation. So it also means that we ask that, especially if that's requested, not to share specific results and data, including through social media. So ideas of people taking photos or other ways of sharing text of information that's presented, we really ask that people recognize the stage of the work that it's at, and not to do so unless a presenter has said that it's okay. So thank you for that in advance. I wanted to take this opportunity now to go through our schedule for the day, and this schedule is going to be similar to the schedules in other summit sessions. So you can see how you can participate in the different ways as you also consider participation at the next session in March and the subsequent ones in May. We are going to quickly shortly turn to Kyle, who's going to deliver what I know will be a really wonderful plenary presentation. And then we will move to having 4 presentations from submitted abstracts on different topics. Again, looking forward to those presentations. And then we thought we would try something a little different to us at the summit, really missing the opportunity to have deeper conversations with people. And so we've added in 15 minutes at the end for small group sharing, and where we'll be in breakout rooms. And it's it's an opportunity for us to see and talk to other colleagues. So we'll be divided into groups, and it won't be it'll be a semi-structured conversation. We have a few questions to help guide the conversation, but we also know that this might be a time when people want to bring up other things and just check in with those in other ways who are in their breakout room. And hopefully we'll each see some old friends and make some new ones, but with the opportunity to have some small group networking. So looking forward to that at the end of this session and at the end of the other sessions. And then we'll come back at the end for some closing remarks. So I very much am looking forward to the next few hours. And with that, I think I'm going to turn over to you, Annalise, to introduce Kyle and get on with hearing his keynote presentation.
Perfect. Thanks, Lisa. And I will quickly go through Kyle's bio. I'll just stop sharing my screen so we can get up his slides. And while he's doing that, Kyle John Wilby is an associate professor at the College of Pharmacy, the Faculty of Health at Dalhousie University. He has a Bachelor of Science in Pharmacy from the University of Saskatchewan, a postgraduate PharmD from the University of British Columbia, and a PhD in Health Professions Education from Maastricht University. He has spent the last 10 years working abroad in Ghana, Qatar, and most recently New Zealand in academic and administrative positions. His research interests include health professions education, 2S LGBTQ+ health and education, systems-based inclusivity, and workforce development. He's published over 130 peer-reviewed articles and is an associate editor for the American Journal of Pharmaceutical Education. He has a cat named Ash, loves to run, and is very eager to keep working on his travel scratch map. Thank you so much and welcome, Kyle. I'll pass it over to you.
Thanks so much, Annalise. Everyone that if you don't know me yet, you'll know I'm obsessed with my cat. I think he makes an appearance in these slides pretty shortly. And thanks so much for the awesome organization of this event and to Lisa too for the introduction. It's really great to be here today with all of you. This year has been a wonderful year for me, reconnecting with colleagues in Canada after being away for so long and being able to get a bit of a landscape of what's happening in Canada in terms of the research landscape and pharmacy practice in particular. And this topic I find is really interesting. So I think we need to start to think more about how we can use research to inform education. And in particular, the lens I want to provide today is how we can actually maximize the impact of other research through the education sector. So I hope it's of use to you and look forward to spending the next 20 or so minutes with you and then hearing what the other presentations have to say as well. Just figure out the mouse. So I did promise a cat photo. This is Ash. This is what I woke up to today in Halifax. So after basically not having winter for 10 years, this is now our new normal. And Ash traveled with me from New Zealand. So he spends most of his time chasing snowflakes through our windows and looking out over Goresbrook Park. But fortunately, I'm looking west towards Ontario right now, and it's clear skies ahead. So things definitely improved throughout the day today. Here's my disclosure statement. Annalise, I hope I did this correct, but I don't have any disclosures to provide. Just highlighted there that I don't have any financial or otherwise affiliations. Any funded research I have in this presentation, I've listed the funders for each of those projects. All right, so with the topic of the day of using research to inform education, I was really reflecting a lot on what I could bring to you in terms of a new insight or new perspective with respect to pharmacy practice research and clinical research and how we can use that to inform education. And the lens that I thought that might be useful is to really focus on knowledge translation and research impact. It's something that I think as researchers we're all aware of. It's becoming increasingly important for funding applications, as well as just the chance to make sure we get the right impact and maximize the impact from our research project. So today, my primary goal is to do that for you and to bring in some of my experiences working overseas, as well as working in administrative capacities, and then my roles within the pharmacy education journal world. For anyone that hasn't seen a presentation by me before, you will now know that I like to use a lot of photos and not a lot of words. Students didn't like that at first, but I think we're changing that to less to memorize and more to understand, hopefully. But this slide here is really a description of the types of impacts that we look for traditionally in research, and not a new slide for everyone, but really here designating the patient, the impact on the patient and patient care as pharmacists and health researchers. Really that's why we are in this field. A number of us do research though for the profession, as well as looking at things like workforce development or interprofessional relations. And also here, this is meant to depict society. So whether that's a drug utilization study or a study looking at more social or cultural aspects of care. This quadrant up here, I argue we don't look at as much in terms of impact. And I think there's a lot of potential there. And this is what I'm hoping to share with you today. And this is to represent the learner, whether that's a student in an entry to practice program or a learner within a continuing professional development environment. So this is going to be the focus of today's presentation, is how we can use our research from other disciplines to maximize the impact on this learner. And who doesn't love a good Venn diagram? But I've tried to designate the major fields where I find most people label themselves as researchers. And I think as pharmacists, sometimes we do like to label ourselves in different areas, but I like what I'm seeing now where people are transcending different areas in terms of health services research as a whole or different types of programs. But as I put this together in terms of clinical research or pharmacy practice research and education research, it really helped me reflect on how I've grown as a researcher, and I'm using different components of each of these to help inform my work that I'm doing now when back in Canada. When I was in Qatar, I started there in 2012. I was very focused on clinical. That was my mandate from Peter Jewison. I was working within a hospital. But then just a couple of years later, I met somebody named Zubin Austin, who you may have heard of, and randomly found myself in a PhD program in pharmacy education. I still don't entirely know how that happened. And I think people like Jamie Keller and Carrie Wilbur might also have a similar experience to me there. And as I was leaving Qatar and entering New Zealand, I was really focused on pharmacy education research. And now coming back to Canada, I'm finding I'm intersecting more and using the experience I've had in each of these components and really working towards pharmacy practice research initiatives, but tying in what I've learned throughout these different areas. And this is what I'm trying to do as a researcher now, is strive to look for the intersections between these and to determine how we can foster impact within each of the different sectors or areas that we're contributing to as a professional research machine. And I do argue that pharmacy education, the impacts in pharmacy education are less on our radar, and that's what I'm going to, again, go over with you today. This is a very simple schematic, but it's really just to introduce the next slide. So if we're thinking about designing a study, obviously we have study planning, you're going to then implement your study, you're going to do data analysis for that study, then eventually get to your dissemination plan. And with your dissemination plan, there really will be implications. And when we write manuscripts, when we structure discussions, commonly we will write about those implications within those discussions. And what I commonly see when I read pharmacy practice research or review pharmacy practice research, or even things that come through the journals that I'm a part of, like RSAF or HAPE, is this kind of statement like this. It's the study also has implications for pharmacy education curriculum and continuing professional development. And we don't go beyond that. We've got lots of great implications for patient care, lots of great implications for the profession in terms of different processes or different ways and efficiencies of doing things. But when we think about our education implications, it sometimes comes out as an afterthought. Hey, this would be great to put into a curriculum, but really, how are we going to do that? And so I really challenge Canadian researchers to help change this narrative and to use your pharmacy practice research and to use clinical research to foster greater outcomes in this area. And as now an associate editor for HAPE, we're really looking for this type of work, and I'm hoping to facilitate some discussion about that by the end of this presentation. So how can we do that? Well, actually isn't rocket science. There's a few tips and tricks along the way, but I have identified a few strategies that I wanted to share with you today that I've learned along the way, or from, again, my different roles in different environments. And the areas that I think we can really focus on in order to make these impacts happen and to really expand your knowledge translation activities into the education sector, which will not only benefit your research project and getting the most impact, but also benefit the education sector, is planning, aligning, and reach. And little known fact about me, but my father was a golf pro on the CPGA tour. And I think, as Lisa said, there's constructive feedback for speakers. So I'm happy to entertain constructive feedback on my golf swing in the chat or in a live Q&A after this. But it's maybe not a coincidence that spells par in terms of plan, align, and reach. And this picture here was actually taken in Doha, the Doha International Golf Course in Qatar. And if you're anything like me and like to avoid the sand, just keep in mind that basically the entire rough on this golf course is one huge sand trap. So might not be your course of choice unless you really like to go to the beach or pretend that you're at the beach. So coming back to this slide, how can we really foster this impact in terms of increasing knowledge translation activities in education? I'm going to take you through each of these different components. So in terms of plan, as researchers, we like to build the best teams possible. And I think that teamwork is really something that can make or break a project. And Annalise and I had some good discussions about this actually while we were discussing this presentation. And I've been part of teams that have been really effective, and I've been part of teams that have been really ineffective. And the effective teams I've been a part of are usually when we have a lot of diversity. So whether that's diversity in backgrounds or diversity in expertise. A good example is down in New Zealand was working with pharmacy practice researchers and also aligning with the likes of Carl O'Mara, where we were able to combine our disciplines and work really well together. And in terms of maximizing impact of knowledge translation activities and impact of your research, I strategically now build teams, and I encourage you to do this too, to incorporate people from different sectors that might have a different perspective in terms of the areas you want to target specifically for knowledge translation. And as an educationalist, I do advocate, and the presentation is about education, of course, to include a collaborator who has that education expertise, because they can really enhance the impact of your project, and not just in knowledge translation at the end, but really in developing the research questions. And that's going to really be the focus moving forward from here. And so this component here is really to promote researchers to include education research questions within their proposals and within the start of the projects, and not making education implications an afterthought. So when you're developing your funding applications or you're developing your study plans, you might have something about a training program, or you might have, if you're doing an implementation science project, there might be learnings from that that are going to be relevant for education. And pulling that out as a research question to begin with can be a really effective strategy of setting yourself up to have a impactful result and something that is might be able to be taken up by an education program and also be publishable for a more global audience. So what do I mean by those research questions? And this is where alignment comes in here. And I see a lot of work coming through AJPE, and I've also been on currents in pharmacy education, where people will ask questions saying, what is the effectiveness of this training program? Or you look at the different abstracts today, deprescribing, opioid stewardship, antimicrobial stewardship, and community pharmacy-based research, all very great programs. And perhaps there's a training program associated with each of those in terms of pharmacy practice research. And instead of asking questions that are more topic-based, such as how would a training program for I'm just going to pick on antimicrobial stewardship. Antimicrobial stewardship is an effective training, or is a training program on antimicrobial stewardship effective, yay or nay? That's not going to have as much impact as, say, aligning your research questions with other components of education frameworks that exist and that we can use to better support knowledge translation down the line. And so one of the things that I find when I was working as an academic administrator is I would have many people come to me as the curriculum lead and say, hey, Kyle, we need to teach this new topic, whether it was a new cancer topic, or maybe it was a new service that was being provided. The New Zealand Pharmacists did these strange kind of accreditations for services. And so that was constantly something that was coming my way. And we're currently in an age in pharmacy education where we're going through I would say a phase of curricular hoarding, where we want to put lots into the curriculum, but we don't have a lot that we can take out or that we want to take out. And there's just a big AACP meeting down in San Diego where the United States is reviewing their accreditation standards, such as Canada, at the same time. And when they asked for advice about curriculum, everyone had things to put in, but all the tweets were about there's really nothing there to take out. And so this is something that we need to be aware of when we are trying to make impacts with our work and with our research and trying to have things integrated within curricula or CPD events. And my point here is that we can do that by making things more outcome focused. So instead of designing the research question to evaluate a specific training program or looking at things from a topic way, start to look at education-based research from a more outcomes way. And that could be aligning things with, say, the AFPC Education Outcome Framework or the NAPRA Professional Competency Framework, in order to show how your research may affect multiple outcomes that could be incorporated within the program. So an example of this, for instance, is we're implementing a curriculum for LGBTQ health that's going to be core within the Dalhousie program. But instead of looking at it as a silo, as a topic, we've looked at it from, okay, which components of this are related to scholar, which are related to care provider, which are related to health advocate, so on and so forth. So when we're teaching those components, we can be using these as examples rather than having to think of things as a specific topic or module. And it's just a way to maybe be better suited and have a better conversation and more effective conversation with those that are designing curriculum. And now this component here is more about bringing that conversation to a global audience. And when we see papers come through journals, again, we look for implications that could contribute to the global workforce or global education sector in general. And lining things with international organizations such as FIP, the Workforce Development Goals, which I have listed here, may have implications for people working in other countries, rather than just limiting the implications to your specific setting. So really my key point here is aligning the research you're doing and modifying the way that research question is asked in order to better support outcome-based learning, rather than looking at something specifically from a specific topic. And we'll come back to this. I have an example at the end to provide to you. In terms of reach, when you have education researchers as part of your team, they should be able to help you navigate where some of those conversations could be had in terms of knowledge translation activities, but to really include education stakeholders in your dissemination plans. So for local impact, identifying groups or individuals who may help facilitate education-related knowledge translation becomes really important. So that could be your curriculum lead or a course coordinator at your local pharmacy school, or potentially leaders of CPD who are working within your province or through your professional organizations. Another area where I've received positive feedback on funding applications, and I don't see that often come through other applications I review, is linking with learner groups. So pre-planning knowledge translation activities with student societies, for example. Students are always looking for lunch and learns. Right now, most are working in virtual spaces, or maybe even having a social media campaign about pharmacy awareness. And linking with those groups can provide you with impact in terms of dissemination of your results throughout different sectors that might, different populations and different sectors that might find that valuable. Especially that social media now, I feel that students are a lot more intuitive with social media than me, even though I like to still think of myself as relatively young, but I don't think I'll be able to say that much longer. I don't think my students will let me say that much longer. In terms of global reach, this is an area I'm going to spend a little bit of time on now for the next couple of slides, because it's quite important when we're thinking about educational research. And I'm commonly seeing pharmacy practice researchers entering into the education space and coming to me and saying, hey, Kyle, I want to have this idea. I did this project and I'd like to submit it to Currents or AJPE, and what are your thoughts? And it's great, and we want people to be working in that space and moving forward. But what we find is this so what factor that commonly comes up with education papers, and you can kind of think about it as a Me Too drug, or we just did this the same but in a different context, or we did this the same kind of measurement but in a different area of the country, or with a different year level of student population. And those are the things that might be interesting locally, but from a global perspective, we need to think a bit beyond that. And there's some tips and tricks in how to do that, and I'll go over a few. And just as a big hint in terms of publishing and education work, when you're putting things such as this is the first of its kind, or it was to our knowledge, this was the first in its setting, that's actually a red flag for us. Whereas, I know in some other aspects like pharmacy practice, that can actually be favored really well, just because we're trying to extend conversations when it comes to education based on those outcomes we talked about on the last slide, rather than always bringing in something new. And this is such a major problem within the education literature space that we've developed a lot of resources for it. So Christian Yankee, who was at Dalhousie and is now down in Minnesota, and quite a major mentor of mine, we co-led this series, which we called Solo Quick Start series, but is really relevant to educational research as a whole, and for anyone that's really wanting to get involved in publishing within the education sphere, perhaps transforming some of your practice findings into education papers. The link is here, and these are all scholarly blog posts, so only 800 words long, usually pretty funny, and are posted on Pulses, which is the Currents in Pharmacy Teaching and Learning web platform in terms of a scholarly blog. So they are peer-reviewed. And I'm going to go over the first one in more detail, but just a shout out to Carrie Wilbur and Terry Cheryl from BBC in Alberta are also co-authors on these. But if you are interested in seeing, having a glimpse of married Douglas Smith from South Carolina and my past dating life gone wrong, not together, separately, we do have an interesting one of discussions of authorship. And I know Melanie McInnes is in the audience, so I'm gonna give a shout out to the boy bands out there, where Jordan Colby and I published a lot about the so what question, linking all of our concepts to YouTube videos of Backstreet Boys videos. So again, an interesting resource, which not just about reading and learning, but also about having fun along the way. And I encourage you to take a look at these because we're actually seeing these cited now in papers coming through, and have been getting positive feedback that it's actually quite helpful. But the one I wanted to talk about a little bit more, just to kind of reinforce that point of how education papers might differ from research that occurs in pharmacy practice and clinical sciences, is one that Kristen and I wrote about what do conference receptions and scholarly writing have in common. And so this will be interesting. Maybe in the small group sessions, we can practice this a little bit. But I hope that one day soon, we're all back at a conference. Maybe it'll be CPERC and St. John's, hopefully. I know that it's planned to go ahead so far, where when you enter a conference reception and you see your colleagues perhaps standing around a table and having an animated conversation, typically you wouldn't just run up and start speaking about your latest project. Might depend on the context and your relationship with them. But more commonly, you would approach them, get a sense of what the conversation topic was about, try to understand what points have already been made, and then offer in extension in terms of your perspective and your insight, and how you think your work might move that conversation forward. And that's really what we mean by, in the education world, but avoiding that so what factor, avoiding that me too factor. It's building on what has been done and extending things further based on tipping your hat or giving a nod to the authors that have been working in that space. Now, just to summarize some of those points and how that could look in a real project. This is a project I have on the go currently in Nova Scotia. So we're looking at pharmacist independent prescribing of PrEP. So without collaborative practice agreements, which is quite exciting. Only other place in the world right now that can do that is California. You know, Alberta has some special considerations too. In terms of the planning phase of that project, even though I'm on that project and I do have education expertise, we know that there's going to be curricular implications for this. And so we brought in Susan Manser as a program director on our advisory committee, because we want her to be aware of, okay, this is coming. This is going to need to be something that's taught to students down the line in Nova Scotia and at Dalhousie. And so we wanted that voice there. Also, Susan is in charge of the CPE program at Dal. So that was a good two birds with one stone type of situation. We've also included 4 students, undergrad students from the outset, and I'm really excited about this because they've already started to help us with our social media strategy for our knowledge translation activities, and much more than I could have come up with or my colleagues who are co-investigators could have come up with as well. In terms of research questions, we've specified them around workforce development. So instead of saying we have a training program, but instead of saying something like, what is the effectiveness of this training program? Our research question is now, how does PrEP prescribing, or how does training for PrEP prescribing contribute to workforce development, and really aligning it with educational outcome frameworks as well as FIP goals. So it becomes more of an interesting research question rather than looking at the topic itself alone. It's looking at workforce development as a concept. And that's really what I was trying to convey in that second slide there in terms of alignment. This is just a bit of a summary about that. And then finally with REACH, how are we addressing the so what? So that alignment with workforce development is one way. And then we have our plan presentations to curriculum committee, students, and CPD stakeholders upon completion. But the one thing I really like here is that thread of workforce development through as a concept or construct, where that's where this project is going to have hopefully educational impact, even though it is largely a pharmacy practice project. So I think I'm almost out of time, so hopefully that I'm right on track, Annalise, but just to summarize, I'm really excited to see how the projects today shape out and how education's been used both to inform those projects as well as the implication of those projects with respect to pharmacy education as a whole. And to summarize my PAR approach, again, definitely taking criticism on the golf swing if needed. I won't tell my father. The plan is to make educational impacts a forethought, not an afterthought. So put those research questions into your projects from the very beginning. And if you can, link with somebody with education expertise that can help guide that and identify the frameworks that might be useful for your project. Align, really speak the language of education. So bringing in, again, those measurement tools and alignment with respect to educational outcomes and workforce development goals. And then finally, reach, consider all possible stakeholder groups, including learners. And I can't emphasize that enough. And the feedback I've had from funders when I've included learners as a stakeholder group for knowledge translation presentations, that has been quite positive to date. And so that is it for me. Hope we're on time. Feel free to connect with me. I can hardly say new in Halifax now. I've been here since May, but always looking to connect with colleagues across Canada. And I think, Annalise, I'll turn it back to you, or Lisa. I'm not sure who's going to be leading the next section here.
Yeah, perfect, Kyle. Thanks. I will take over from here, and we'll transition to research presentations in a minute. But just before we do that, I'll encourage people. I want to leave a few minutes for questions. So if people do have a question for Kyle, please feel free to type it into the chat box, and I'll read it out. But maybe while just people are thinking about that, Kyle, I really liked your point about how we can need to emphasize continuity rather than this is the first of its kind or this is a brand new program. And I think some of my colleagues on the call might also feel this way, that I think there's been some recent instances of that in both the research and education space when applying for funding or for grant opportunities, and a greater emphasis on new programs or novel programs that are hopefully going to introduce a new finding, and perhaps not as much emphasis on continuity of educational training programs that are working really well and also have research outputs. So I guess my question is just lessons learned on how we can sort of cultivate an awareness of the importance of continuing with initiatives that need sustainability behind them and need support, rather than just kind of turning to the new flashiest thing.
Yeah, no, great comment, Annalise. And it is interesting when you see calls out for, especially innovation calls and those types of things that can kind of counter maybe what we're trying to do in terms of building on what's already good and what's already being done. I think one of the ways we try to strategize that in our groups in the education circles and working for the journals is to start having those conversations more. And by writing, for instance, one of the strategies we're doing is a letter to the editors series. So writing a letter to the editors based on papers that we think there needs to be more conversation about, and drawing that scholarly conversation attention to the academy and to the journal, and then using our professional organizations to leverage that as we go. In terms of actually, creating funding opportunities for those types of things, I'm not sure what the answer would be for that, but I do think if we can have more discussion around that as a whole and the importance of it and drawing it out in the literature in particular, then funders might pick that up and might be able to have different types of calls out for different opportunities.
Yeah, thanks. I think so important. I think we sometimes trying to box something into a three-year funding cycle isn't necessarily the best approach or the way to realize some of the outcomes. So I think, Dale, I know you left a comment in the chat as well about an emphasis on outcomes would be very welcome. I know it's some of the CFP work, so I think that point is well appreciated. I'll maybe just read out Lisa's question before we transition to our research presentations. Lisa asks, what is the advice you have given, what is the advice you have given all that we have experienced in COVID, and how what we did before and integrated that into pharmacy education going forward? I expect we need research in so many areas, it's hard to prioritize.
Yeah, I think it's a great question, Lisa. And what I'm seeing, it's funny because on Currents, we had a whole team devoted for COVID papers when COVID happened and everyone was, we put our course online and we're going to publish it, which, got, I think a lot of people did that quite effectively moving forward. So I think now where we're at is really looking at how we can integrate during COVID and pre-COVID, and looking at how we can build on those outcomes that I talked about. So for instance, there's a lot of work being done right now in the online world, and I'm going to use Health Advocate as an example, as an outcome to take a look at. Pre-COVID, we'd probably talk a lot about how you would navigate someone through the healthcare, through referral or different aspects in the skills lab, that type of thing. During COVID, I think we learned a lot about what we can do virtually and how we can advocate for people using other mechanisms and not just always that face-to-face interaction. But putting some research around that and understanding how students can achieve learning outcomes using those different models of learning, I think is really important. And really, if you think about the so what factor, kind of when you're writing your papers or designing your projects, tipping your hat to what was done pre-COVID, but then extending on why is this different and how might this enhance that student's learning, I think is really the way forward. And if you can successfully do that, I believe that would be a great outcome for a paper and something that would be interesting to the academy as a whole.
Great, thank you so much, Kyle. So I'll just encourage people online, if you want to, I'm speaking for Kyle, but if you want to follow up with him in the chat box or via email on research, education, golf, or otherwise, I'll leave that up to people online. But on behalf of Open, thanks, Kyle. That was a very, very insightful talk. And I think, I have lots I'm left thinking about, and I like the PAR acronym as well. So thanks for that. Just transitioning into our first research presentation for today, I'll introduce Brian Chow and ALEXI YUZWENKO. Brian and ALEXI, if you are able to share your screen, I think I've set you both up as co-hosts. So while you're doing that, I'll maybe just introduce the two of them. So Brian is a fourth-year pharmacy student in the class of 2022 from the University of Alberta, and he's looking forward to starting his career as a pharmacist for Rexall. Born and raised in Edmonton, Alberta, Brian knew from high school that he wanted to be a pharmacist, and through pharmacy school has gained a deeper interest in geriatrics, hopefully genetics as well. And ALEXI is currently in her fourth year of the Entry to Practice Doctor of Pharmacy program, also at the University of Alberta. She'll be graduating in June and will be starting her year one residency in Red Deer, Alberta as of July. So welcome both, and I'll turn it over to you to get us started.
Thank you. And can you hear me okay?
Yep, sounds good.
All right, awesome. Well, hello everyone, and thank you so much for the introductions, Annalise. And on behalf of the research team, I would like to introduce our ongoing project on education about deprescribing for pre-licensed and licensed healthcare professionals, a scoping review. Just to start, I would like to say, that ALEXI, Liz, the librarian, and I do not have any conflicts of interest to disclose. And Dr. CHERYL Sadowski, our supervisor, is a member of the Canadian Deprescribing Network. And she also has previously received funding for community pharmacist interventions for lower UTIs, lower urinary tract symptoms, and is independent from the project and should not affect our results.
Okay, so starting off with the background, polypharmacy and potentially inappropriate medications are very prevalent in our health system, and they have been shown to negatively impact patients' quality of life. Approximately 50% of Canadian older adults utilize at least one PIM. Approximately 35% of adults in the United States, ages 60 to 79, use greater than or equal to 5 prescription medications. And there also has been a 24% increase in the total doses of medications consumed globally between 2015 to 2020.
So for our scoping review, we did utilize the 5-step framework for scoping reviews, first introduced by Arksy and O'Malley with advancements by Levesque. And our education question is as follows. What educational approaches have been utilized in pre-licensed and licensed healthcare professionals to increase knowledge and skills in deprescribing? And the objectives that we wanted to have going into this was identify the preferred approach using to teach deprescribing, describe the differences in teaching, learning, and content for licensed physicians, pharmacists, and nurses, as we felt those were the most likely to implement deep prescribing, as well as look at those healthcare professions, but for students. And lastly, try to describe any barriers or facilitators in teaching deep prescribing.
So we did have Liz, the librarian, help conduct our search in Medline, Scopus, Embase, and ERIC. The search strategy was quite broad for deep prescribing education for healthcare providers, with no limits on the setting, location, or type of paper. We did also include conference abstracts, just to make sure that we were not missing out on any relevant research.
So here's our Prisma diagram, which our search yielded about 2,500 results. Quite the task, but we did manage to narrow it down to 38 papers, including 24 full texts, or 20 full texts that had interventions, 14 conference abstracts, and 4 white papers that were somewhat like commentaries about deep prescribing education. So for our first objective of finding out the preferred approach using to teach deep prescribing, we split into the type of delivery method, as well as how many individuals a particular intervention targeted at one time. The first diagram here, delivery of education, the most common form of education was workshops, followed closely by lectures. And as you can see, as we trail further along the graph, we get to more one-on-one delivery methods like academic detailing or experiential education. This is also reflected in our second diagram here as a teaching style where most interventions did utilize group education, like workshops and lectures and such, with less emphasis on self-directed learning or one-on-one.
So here we combined our second and third objectives, which are the differences between professions divided into practicing health professions and students. Most of the interventions in the literature actually included multiple professions in their intervention, and the majority of studies that only included one profession targeted either physicians, residents, or medical students. So therefore, for this objective, it was a bit difficult to draw conclusion to the question that we posed with the available published literature. Although to note, none of the papers included involved pharmacy students or nursing students. So this is a gap that we found in the literature.
And for our fourth and final objective, to determine the barriers and facilitators of teaching. Now, most of the papers sadly did not address or publish the barriers to teaching deep prescribing specifically, but would more commonly discuss the barriers to implementing deep prescribing. And it was not clear whether when going through the literature, if the barriers of education was supposed to be extrapolated from the barriers of implementation. Facilitators, on the other hand, did have some more tangible points, including one paper who taught medical students. The students said that they enjoyed interactive cases with peer learning, as they felt that it was much more engaging for them. Other facilitators of education included a study where they educated an entire health organization and used actual patient cases in which they found that it was effective as learners felt that they could apply themselves to a more realistic case and almost physically put themselves in those situations. And lastly, I just want to put here a quick summary of our outcomes that we kind of looked at. And to note, this table does take into account papers which did have multiple outcomes. And in summary, most of the papers targeted numbers of medications prescribers would want to deprescribe or consider deprescribing, followed by learner self-efficacy or learner knowledge. And surprisingly, not that many papers actually did address or publish results on course evaluations.
So to highlight, based on our scoping review, the preferred method of teaching deprescribing is workshops with multiple learners and multiple professions. But this does beg the question if this is the best method of teaching. It is difficult to say what the differences in teaching between professions is, given the data that we currently have. And in regards to the quality of evidence that we found that there was little rationale for the type of education provided in the intervention. Many studies also only briefly describe their intervention, which makes it very difficult to replicate. And the majority did not include a comparator group. Lastly, most studies looked at outcomes immediately after the intervention rather than delayed recall and use of knowledge in the long term.
So finally, what can you do to advance this new and exciting area of research? Well, first, we implore all education programs out there to share and explain their experiences of teaching deprescribing, as there is almost no literature on healthcare curricula. And they could use, or other programs could use this information to help develop their curricula as well. Next, a common objective with similar outcomes, such as identification of PIMS or learner self-efficacy, could try to be used for future research to try to get around the issue that we found of comparability as well as small sample sizes. And lastly, don't be afraid of trying new ideas. We saw a relatively limited variety of education, meaning that there's still lots of room for growth. And with that, thank you for listening to our presentation and happy to take any questions.
Perfect. Thank you both. I have just put in a plug. If people have questions, they can type them into the chat box. But thank you so much for that quick overview and highlighting some of the research that you two have done. I guess to get us started, I'm just curious, you're both currently students in pharmacy. I was very struck by kind of one of the first slides that you put up, that there are very few deprescribing initiatives or education aimed at students. So I was just curious if either of you had any thoughts of how we can perhaps improve that for health professions as a whole, but also for pharmacy students specifically.
Yeah, thank you.
You can go, Alexi, you go.
Sorry. Thanks for the question. Yeah, in my opinion, I think from my experience as a pharmacy student, they do have some initiatives that they've presented at the University of Alberta to teach us deprescribing, but I think that there's kind of just a lack of research published on this area. So I think it is happening in multiple student populations in different professions, but I think that there's just kind of a lack of sharing that information. And I know with education, it can be difficult to kind of have those outcomes and assessing those, especially in the long term, which is likely a reason why a lot of the studies actually looked at it more short-term retention and recall of knowledge. But I think that there's just kind of a lack of publication about information in this area for students.
And I kind of want to echo that thought as well, is that we do know that it's out there, but we just kind of want to do what is actually published. And I'm sure there is sharings of ideas, but like all of our clinical professors taught us, if we didn't document it, it didn't happen. So it's kind of like that same principle as well. So
thanks, Brian. That sounds like a good title for a research paper on this topic, maybe. I'll quickly transition just to the chat, a few questions coming in. From Natalie, for the studies that you identified, did they tend to target one professional, or were there interprofessional programs, and across what groups?
Yeah, so most of the interventions, they did target multiple professions. And then the ones that did only target one profession was mostly the medical profession, with either physicians, medical students, or residents. But there were quite a few of interprofessional education initiatives with physicians, nursing, and pharmacists as well.
Great, thanks. And then just a question from Barb, who I know would be very interested in this work. Did your search capture primarily evaluations of education interventions, or did it also capture published case reports, online modules, apps, etc., that facilitate deprescribing training?
We try to keep it as broad as possible. So if they were published, we did include them. So yeah, it kind of had a very, very wide range. We had things like some were just a video and then kind of like a little quiz afterwards, and other ones were like multiple session workshops as well. So it was quite comprehensive.
Yeah, no, that's great. And I know you mentioned there are some white papers and conference abstracts in there, and those can tend to have some different things. So That's exciting. Barb's next question, are you publishing?
Almost.
Yeah, we're getting there. We're just working on some finishing touches. It's been a bit longer than I think Brian and I both expected, but I think speaking for both of us, we're really happy and proud of this research and kind of want to disseminate it out. So in the future.
Fantastic. Congratulations to you both. And I think that's really nice to be able to work on it together. I think Kyle pointed to that in his keynote presentation of hiring 4 research assistants on or undergraduate students. And I think that can be really, really rewarding to also do that together. So thank you, Brian and Alexi. Thank you so much for your presentation. And we will transition to our next research presentation for today. Atta, I'll let you put up your slides just as I read out your bio. ATTA NAQVI is a lecturer at the School of Pharmacy at the University of Reading in the UK. Dr. Naqvi has recently completed his postdoctoral fellowship at the School of Pharmacy at the University of Waterloo. He has over 7 years of teaching experience and has published over 100 research articles. He's previously worked in different academic settings in Malaysia, Saudi Arabia, and Pakistan. His research interests include evaluating pharmacy health services and pharmacists' role in improving patients' treatment outcomes. Welcome. I'll turn it over to you.
Thank you, Annalise, for the introduction, and good afternoon, everyone. So I'm here to present my research that I completed during my postdoctoral fellowship at School of Pharmacy, University of Waterloo last year. And under the supervision of Dr. Frank Chang, and my co-investigators were Christoph and Eric, who are pharmacists and working in family health teams. So we wanted to understand the current role of primary care team-based pharmacists in opioid stewardship, their self-perceived confidence and importance. So before I begin, I would like to declare that I have no affiliation, financial or otherwise, with a pharmaceutical, medical device, or a communication organization. So when we talk about opioid stewardship, so it's chronic pain, and chronic pain is a complex condition, and it's usually a very common condition observed in primary care settings in Canada. The prevalence, as per the available literature, for chronic pain is between 5% to 55%, depending upon the location. And depending upon the severity and nature of the chronic pain, some of the medications, one of the medications is opioids. So if the chronic pain is quite difficult to manage, so sometimes high-risk medications such as opioids are frequently prescribed. And one thing to consider while prescribing opioids is to ensure that the therapy is rationalized and justified, because opioids might have side effects that might be difficult to manage. And we know that from the available body of evidence that pharmacists collaborating with prescribers in clinical settings, particularly primary care settings, do have the potential to improve pain management and ensure a safe and effective therapy. Primary care, team-based concept is a new concept. Now, I would say a relatively new concept. Ontario embraced this concept in 2005, and currently around 25% of Ontarians utilize this primary care setting, team-based settings. And primary care team-based settings are basically organizations such as the family health teams, community health centers, that include a team of healthcare professionals working together as a team to provide patient care for the community. And although in opioid stewardship, in terms of opioid stewardship, particularly the pharmacist role, there have been guidelines that are published. There have been some quality standards that are given, but that is in the books. And currently, we don't have any evidence to know what the pharmacists are currently doing in this practice. So the pharmacist's role in chronic pain management and opioid stewardship is not well documented, and that is our objective, or rather was our objective. So we wanted to understand the current role of the primary care team pharmacists in opioid stewardship and their self-perceived confidence and importance. For this purpose, we conducted a 2-month cross-sectional study using an online survey. We used Qualtrics as a platform for the survey, and our target population was the pharmacists working in team-based setting across Ontario. The literature highlights that there are around 200 pharmacists working currently associated with these practices. And we invited pharmacists to participate by email through the Ontario College of Pharmacists members database and the Ontario Impact Net Pharmacist Network. So we developed a questionnaire for this study, and it was for the development of this questionnaire, we set up a panel of experts that consisted of pharmacists and academicians. The panel reviewed the existing literature, the guidelines, and the quality standards that were available for highlighting the role of pharmacists in opioid stewardship. And we utilized the Delphi consensus method for the development. The whole process took place in 4 rounds of an internal review, followed by a peer review, and we also conducted face and content validation. Once the questionnaire was ready, before the actual study, we also conducted a pilot study on 6 respondents just to check if everything was fine. At this point, the questionnaire was just deemed suitable for the actual study. So regarding the results, so we were fortunate to gather around 88 responses, and the response rate was around 40%, which was quite good considering the level of work and the extensive engagement pharmacists had in their daily practices. So as you can see from the graph, that most of the pharmacists were in age groups between 40 to 50. So we have a fairly mature population, and most of them were females. Regarding the education, so this was a multi-select option, so meaning that they could select more than one option. So more than half of the population had a BSc in pharmacy, some were residency trained, some had a PharmD as well. In terms of work experience, roughly half of the segment had more than 20 years of work experience, which was quite consistent with the age of the pharmacists that we had. And also this, in some aspect, justifies that and make them an ideal population to answer the research question. In terms of practice locations, so we are fortunate to gather data from a very good geographical distribution that we had, ranging from metropolitan towns to small rural towns. In terms of settings, more than half of the pharmacists were working in family health teams. So when it came to collaboration with prescriber colleagues, so a quarter of the pharmacists were collaborating with their prescriber colleagues using my practice report for opioid stewardship. Just to explain briefly about my practice report, so it's a kind of a report that was jointly prepared by the Health Quality in Ontario and Association of Family Health Team Ontario, and also the School of College of Physicians and Surgeons. And this report was basically what it does. It examines the data specific to a group or the individual prescribers in order to identify the gaps that might exist and offer practice ideas for improvement. These reports show information about the practice in relation to the region or the province, and also provides data about the opioid prescribing patterns, so that the prescriber can look at the data and try to see where the gap exists and try to improve their practice. Team-based care is all about advancing the interprofessional care and the standard of care, but we noticed that pharmacists reported there are some barriers when collaborating with other healthcare professionals. So the most common barrier was time, and followed by resources that included money, human resource, office space, and facilities. In terms of frequency of carrying out opioid-related tasks on a scale of 1 to 5, where 1 meant never and 5 meant always, so the most frequent tasks performed by pharmacists were providing education to patients, opioid education to patients, calculating morphine equivalents, and conducting medication reconciliation. And the least frequent tasks were performing opioid rotation, assisting and interpreting the urine drug screening results, independently performing tapering or discontinuation of opioids. And not surprisingly, this frequency translated into the confidence. So the results were quite similar when they were asked to rate their confidence in carrying out opioid-related tasks on a scale of 1 to 5, where 1 meant no confidence and 5 meant very confident. So they expressed confidence in calculating morphine equivalents, providing education to patients, and conducting medication reconciliation. And the least confidence was seen in performing opioid rotation and recommending urine drug screening, for instance. Interestingly, similar results were obtained when pharmacists were asked to rate the opioid-related tasks regarding their importance in opioid stewardship practice on a scale of 1 to 5, where 1 meant least important and 5 meant extremely important. Similar trend was seen, and the most important tasks were providing education to patients, conducting medication reconciliation, and calculating morphine equivalents. And the tasks of low importance or the least important tasks were the performing opioid rotation, independently performing tapering, and recommending urine drug screening. So here I would like to take a moment to discuss the available evidence that we have. So review of the current evidence shows that in an opioid stewardship, pharmacist interventions such as therapy adjustment and medication review had the most highest level of evidence in terms of quality and quantity. And it highlighted that these two interventions, such as the therapy adjustment and medication review, were significantly related with improving patient outcomes in chronic pain management. So to summarize, our study found out that many pharmacists commonly routinely engage in chronic pain management or opioid stewardship activities, but they mostly conduct activities in a supporting role. And the frequency of such activities translates into confidence and a self-perceived importance of those tasks. And some of the tasks, such as opioid tapering, which according to the evidence has the highest potential to improve the patient outcomes, were seen to be the least frequent, and pharmacists considered them as one of the least important tasks. So this highlights that on a positive note, there is an opportunity that exists in the primary care team's landscape that pharmacists can capitalize on and try to optimize their role by assuming a more proactive role in these settings, support the evidence-based practice that is seen there, and try to promote their full scope of practice so that they can try to achieve more comprehensively and significantly better patient outcomes. This research also highlighted that where the pharmacists stand at the moment and where should they be, and what are the gaps that exist, and how the gaps can be fulfilled, and how can pharmacists utilize the full potential in improving the patient outcomes when it comes to chronic pain management. In the end, I would like to acknowledge that this study was funded by Health Canada, and I would also like to thank everyone mentioned here for their indispensable help during the course of this research. And thank you so much. And I can still be reached at my UW School of Pharmacy email address, and my supervisor can be reached at UW School of Pharmacy email address as well. And thank you so much for listening, and I'm open to questions.
Perfect. Wonderful. Thank you so much. Really nice to see some of that work. It's something we talk about and have been anticipating hearing about quite often in some of our primary care working group meetings. So it's very exciting for me to see the results of this. Curious, Atta, if there was anything that surprised you with any of these findings? Was there anything unexpected or that you didn't anticipate?
Yeah, I mean, we were expecting the trend to continue, what we saw in the literature. So our team members were working on the current literature. So the literature that I showed here in the slide that I discussed, this was done by our team member also. So we were expecting the same trend to follow, and it was like an open ground because it has never been documented. So our expectation was that the trend would continue because the existing literature is predominantly North American. So, but we were quite surprised to see that there is I want to put it in a positive way, that there is still a gap, or there's an opportunity for our Canadian pharmacist colleagues to, fulfill that gap and try to assume a role of, more clinical role to adjust the therapy so that the potential to improve patient outcome in this practice may increase significantly. So this was the thing that we were expecting, and this was the difference that we encountered.
Great. Thank you so much. In the interest of time, I'm going to keep us moving along, but I'll just encourage anyone else to maybe have a bit of back and forth via the chat box. So thank you so much.
Thank you.
Our next presenter for today is CHERYL Sadowski. So I'll just introduce CHERYL as she gets her slides up. I can just see, sorry, Greg has put a question in the chat, so I'll just let you respond to that, Atta. CHERYL is a professor at the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta. She's a specialist in geriatrics, not genetics, and her research interests include management of geriatric syndromes and medication safety in older adults. CHERYL, over to you.
Okay, I'll try to share my slides. Is it possible to have the other slides unshared?
Atta, are you able to, actually, I might be able to, yeah, Atta, if you're able to remove your shared screen. Okay, and
looks like
CHERYL, you should be able to now. Sorry about that.
Okay, you can probably, let me swap that. How's that? Is that the full slide?
Yeah, perfect.
Okay, all right. Thank you. And I appreciate being accepted to present at the Open Conference. I've attended before, but it's nice to be part of the discussion today as well. I'm going to speak today about barriers and facilitators to pharmacy practice research in the community. And I'm presenting on behalf of a team. I'll point out first, our student, Julia Vu, is not able to join today, but she has no conflicts of interest to disclose. My colleague, Dr. Yazid Al-Hamarne, is on the discussion on the panel today as well, and has a number of funding sources related to industry and others. And in fact, between the grant that we share from Pfizer related to a study on lower urinary tract symptoms, that's actually what triggered this particular research. I'm also a member of the Canadian Deprescribing Network, and nothing in this particular presentation relates to deprescribing. I will comment that most of us know about pharmacy practice research. There's been a whole generation exposed to this. Probably one of the leaders was Dr. Ross Siyuki, who is now at the University of Alberta with the SCRIPT study. So that study found that pharmacists improved so many outcomes, including mortality, and that kind of set the standard for other research into pharmacy practice. Over that 25 years, we've seen a growth in chronic diseases, health system costs, but also growth in the pharmacy scope of practice. So as we've also seen a growth in aging and more older adults, we have more geriatric syndromes that we need to be addressing or could be addressed in the community. And that made us interested in starting the pilot study, which is our acronym for Pharmacist Intervention for Lower Urinary Tract Symptoms, which includes urinary incontinence. So we received funding for this, I'll acknowledge, through Pfizer, and we wanted to have community pharmacists identify do some assessment and some intervention related to lower urinary tract symptoms in the community pharmacy. We built the budget to include some funding, and we did some training, and we were really excited about the project. And then COVID hit, but we also encountered quite a few other barriers. So this was really a challenge for us, this particular study, and that's what triggered us to want to do this particular search on what are the barriers and enablers for pharmacy practice research. So our methods, we decided, given the timeline we had with our window of funding to do the pilot study, and in trying to address some of the issues that we could, we decided a narrative review was appropriate based on our resources. And our focus was on pharmacy practice research in a community pharmacy. And the focus had to be to involve pharmacists. We were only looking at the pharmacists, not the rest of the pharmacy team, because activities such as prescribing, et cetera, could have been involved. So we used pretty standard review supports and resources. We worked with the librarian, downloaded our resources into Covidence, and had predetermined what we were going to be extracting. So I'll spend the next few minutes talking about our results. We were able to find 35 different studies over a 25-year period. So like I said, that's about the history for pharmacy practice research, about one generation, and but from quite a few countries, which is really positive. We found that there was quite a bit of information about the different kinds of outcomes, what they were looking for. There's a diversity in methods. There was only one RCT related to how pharmacists were engaging in research, but lots of questions, interviews, surveys, etc. And quite a bit of information about the pharmacist and pharmacy characteristics. So I'll start by presenting the facilitators. I'll try to start with something positive, what works. Well, I guess it doesn't surprise us that altruism might fit in here. So this is something related to, on the left-hand side, intrinsic motivators. So this is wanting to improve patient health, caring about advancing the profession. So pharmacists really do care about health outcomes. They care about pharmacists being essential healthcare providers. What we found less commonly were extrinsic motivators. So if we shift to the right of this particular graph, business competition, offering continuing education credits, this was not particularly motivating in most cases. What we did find is that research operations, such as the complexity and how pharmacists would feel overwhelmed, there were a consideration. In terms of the pharmacist characteristics on the far right, this was really quite a mix, and a lot of diversity within the literature on this. You can see only 7 studies included these characteristics, though. So in some cases, the authors found that females were more likely to be involved in research. A younger or less experienced pharmacist was more likely to be involved. And then other studies found like it didn't matter. They just had pharmacists were interested or they weren't, just as a whole. So we found overall the characteristics were a little bit contradictory. If we look at pharmacy-specific facilitators, it's not surprising pharmacists don't work in isolation, so having support of the entire team, ability to delegate or have other resources, or having one pharmacist out of many perhaps involved in a study was something that was supportive. You can see other examples here, such as corporate support, relationships with patients, etc. We were a bit surprised that physician support was actually quite low, or not quite as important. Study-specific factors. So it looks like it's quite high here, such as remuneration and training, but I'll point out that's only 6 studies reporting that that's an issue out of the 35 studies that we found. So some pharmacists did seem to believe that compensation would increase participation. And in other studies, it found there might be no difference at all, that it would more be that altruism. Another factor that was very important to us as doing a study on lower urinary tract symptoms is study simplicity. So a geriatric syndrome, such as urinary incontinence, is by nature very complex. It's very difficult to manage syndromes. They're multifactorial, and there's usually multi-component interventions that would address them. So simplicity was a bit of a challenge for our particular study. And researcher communication is important. We'll talk about that in terms of mixed findings there. So over communicating, so almost harassing the pharmacist too much, or the study is in their inbox every day, was not attractive, but also not hearing from the academics was problematic too. So talking about the barriers. There's very little written actually about patient-specific barriers for participating in pharmacy practice research, and yet they're the ones that we are trying to improve the outcomes for. But it seemed like there was just a couple of points that we found in this body of literature. Some patients were not really interested, or they felt that their health condition was well managed enough. They didn't need another intervention. They already see their doctor, thank you very much. And so there's demands placed on patients when they're part of a study as well. And also skepticism. So about pharmacist roles, pharmacist ability, pharmacists being able to prescribe or make these adjustments and not quite trusting or understanding all of the scope that could be involved there. In terms of pharmacist-specific barriers, what really stands out quite dramatically is a lack of confidence in their abilities and knowledge. So that was in almost half of the studies. I'll also point out there is also a concern about an us versus them attitude in a few studies. So that comes through in kind of research literacy and also research perceptions, so that their pharmacy, or they as pharmacists, were just being used by academics, that we had this research question, we were viewing them as, observing them as if they're hamsters or something in a study, rather than really walking alongside them. They're co-designing where they're part of the research. So that was a barrier as well. And then pharmacy specific, it maybe doesn't surprise you, 80% of studies said time, but some of these other factors as we move right across this graph showed other things might contribute to time. So inadequate staffing means the pharmacist has less time because they're doing other activities for their peers or technicians and so on. And also I'll point out, physician resistance often is mentioned in a lot of papers or by some experts in opinion pieces, but we found actually very little published on this as being a barrier for pharmacy practice research. And also other pharmacy considerations might be the time of year, such as influenza season and vaccinations. Study-specific barriers, we had lack of reimbursement, was in 10 of the 35 studies. So at least in our study, we felt we had addressed that. But also the study complexity, which has given us pause because geriatric syndromes are innately complex to address. And then, as I mentioned earlier, researcher communication, too much or too little can be problematic. I'll just pause here to just highlight a couple of significant important findings. The first is that pharmacist mindset really seems to play the most important role in their willingness to participate. We had a number of, the majority of facilitators were intrinsic, and they stem from altruistic and self-interested motives. And pharmacists are well aware of the benefits of research, but there's quite a few mental barriers stopping them, such as a lack of confidence. And researchers need to support pharmacists to feel prepared and confident in order to conduct the research. Remuneration is more of a concern for pharmacists. Time is money, and time is precious. So we should be respecting that, so they don't feel like they're being used, that they're respected for the time they're contributing. But again, if remuneration is not feasible within a particular study, building on altruistic motives there as well. And time is the most significant barrier, but also thinking about if you're selecting a site that you're going to partner with to do research, thinking about, oh, well, that, too bad, I guess that site isn't going to work, but thinking about other ways to support that pharmacist to have time is important. In fact, even funding a staff member to be part of the study. And then finally, pharmacist characteristics are overall pretty poorly described in this particular body of literature. We had expected not just, oh, female pharmacists are interested, males are less interested. It was very simplistic in a few studies, not nearly enough depth in terms of the pharmacist characteristics of what would interest particular pharmacists. And to summarize, these are a few of the recommendations that we found from the literature. So based on the particular barriers and enablers the studies had, then in their discussion, they recommended what to do. So the top two are study simplification and address training. But we have summarized this a little bit differently and not giving it a weight. So we didn't want one item to be more important than the other, but based on our findings, this is what we have synthesized, perhaps a little bit of a checklist for researchers to think about in terms of how they would address the preparation for a research study. So thinking about your design, preparing for the study, and then also issues to consider during the study, and then in follow-up, considering all factors from the pharmacist, pharmacy, the context, etc. So finally, we were surprised by the sheer number of factors. We had focused quite a bit on thinking time was a barrier, but we had paid for their time. We had a fairly simplistic view. So the number of factors, it was far more complex than we had appreciated. We needed to consider these factors in the planning, but we have regrouped and tried to address some of these issues. And we would encourage future research on actual characteristics of the pharmacists and how to measure some of these issues. Just simply putting some buckets there, you were this category of that, was probably not adequate. So I'm happy to answer questions now, but we are sometimes pressed for time here. So I'm also happy to respond by email. You have my address there, Cheryl A.S., Cheryl Sadowski at ualberta.ca. Thank you.
Thank you so much, Cheryl. And yeah, time is always fleeting, but I would like to get maybe to Greg's question in the chat box for you. Did your research identify anything about pharmacist culture and how it is shaped through undergraduate education? How important is engaging in practice research to pharmacists? Said differently, is there any indication that the facilitators or barriers differ for pharmacists from other professions, such as medicine?
We didn't look at other professions, but that's an excellent question. Some of the barriers, such as the individual characteristics, might be transferable, is possible, but the settings may be very different. A community pharmacy setting certainly had certain demands, and that played a role. I will point out that in possibly engaging, there is some evidence that engaging pharmacists a little bit earlier in their career as students, such as Kyle mentioned earlier, is maybe one way. And given that we've had pharmacy practice research only for about 25 years in engaging students in that, we maybe now have a generation where that would be normalized. It would become part of their practice. And that's one approach we've actually taken in our relaunch of this particular study as we're nearing post-COVID and trying to get the study rolling again.
Great, thank you, Cheryl. I'll invite any other questions to Cheryl to just be put into the chat box just as we move to our final research presentation for the day. Catherine, I will ask you to put up your slides just while I introduce you. Yeah, so Catherine KOROLUK is a primary care pharmacist practicing at the Thames Valley Family Health Team, which is in London, Ontario. She's completed a pharmacy residency in primary care at the University Health Network in Toronto and graduated from the University of Toronto with a Bachelor of Science, Doctor of Pharmacy, and most recently successfully defended her Master's of Science thesis in January. Some of her obsessions beyond pharmacy include gardening, being active outdoors, and her dog. Thanks, Catherine. I'll turn it over to you.
Thank you. Thanks so much for the opportunity to present my master's research. I just recently successfully defended, so I'm really excited to present this today. So my study focus was on community pharmacists as antimicrobial stewards with an acute otitis media focus. So Professor Sadowski's research was particularly interesting for me. My supervisor was Marissa Battistella, and my committee members were Lisa McCarthy and Certina Ho. So I did receive an unrestricted research fellowship from Merck Canada as a student when I was conducting this research. So quick background on antimicrobial stewardship and acute otitis media. So as we all know, antibiotic misuse is a really significant public health issue and is a priority for many international organizations, given its worldwide impact. Pharmacists are a pretty foundational part of antimicrobial stewardship programs in institutions, but they are largely absent in the community pharmacy realm. However, they're really well positioned as medication gatekeepers. They ensure safe and effective prescription medication use. And since any antibiotic that's dispensed to an outpatient must first be reviewed by a pharmacist, this is pretty important. So another key factor in antimicrobial stewardship in community pharmacy is that pharmacists can independently adapt prescriptions. So that's a key part of my study and my research. Antibiotic misuse in outpatients is a significant problem, as I mentioned. About 60 to 80% of antibiotics are prescribed for outpatients. 30% of those prescriptions are completely unnecessary, and about 50% of those antibiotic prescriptions are for non-first-line agents. So there's a significant opportunity for improvement. The target focus for my study was acute otitis media. Now this number is a little bit outdated, so I'm sure significantly more nowadays, but there was 1.8 million physician visits per year for acute otitis media in Canada when this statistic was generated, so it's a significant opportunity for improving antibiotic use. Now a quick overview of AOM treatment. Generally, watchful waiting is the first choice, which means that just a general observation and not providing any interventional treatment besides pain control. Most children will self-resolve given the viral nature of AOM. Amoxicillin is the first-line antibiotic of choice, just given its narrower spectrum of activity, and it covers most of the pathogens responsible for AOM. High doses of antibiotics are required in order to achieve a significant concentration in the middle ear. And a 5-day duration of therapy is usually appropriate for most children. Now, these last two components, the dosing and the duration of therapy, are particularly pertinent for community pharmacists because these are the components that they can affect through prescription adaptations. Now, a really quick overview of my framework and research objectives. So my theoretical framework, I used the Kirkpatrick model of training evaluation. There are 4 separate layers. I'll mostly focus on kind of the precipice there, the results section, but I did look at the reaction, learning, and behavior components of my intervention on the pharmacists involved. So the research objectives mapped onto those parts of the theoretical framework. So objective 1 was to evaluate the nature of community pharmacists' reaction to learning from and behavior change after implementing this AMS program. The objective I'll focus on today was to evaluate the impact of a multifaceted community pharmacy-based antimicrobial stewardship program on the rates of guideline adherent antibiotic use for acute otitis media. My methods. My study design was a pre-post non-randomized study. It was set in 2 community pharmacies in Toronto, which were selected as a convenient sample. The pre-intervention part of the study was a retrospective review of pharmacy records, and the post-intervention part was conducted prospectively with the study intervention applied at various points throughout this period. The study population, I had 2 populations of interest. The patient participants were children from 6 months to 12 years of age who had a diagnosis of AOM and who were prescribed oral antibiotics for AOM and presented to the pharmacy with that prescription. The pharmacist participants were any pharmacists who were regularly practicing at either of the 2 study sites. The intervention that I applied was multifaceted in nature because although there's very little research involving community pharmacists and antimicrobial stewardship, the evidence base in outpatients is very clear that multifaceted interventions tend to be more effective, just given the complex nature of the act of prescribing antibiotics. So I used an educational outreach visit where I met with each individual pharmacist participant one-on-one and reviewed an educational module with them. I used a clinical data gathering tool and a clinical decision support tool to help the pharmacists in their clinical decision making, taught them how to use these tools and provided them with them. And then I also conducted monthly audit and feedback with the pharmacists, where I provided written and verbal reports of kind of how their dispensing habits compared with the pharmacists as a whole. And the goal of this intervention was to have pharmacists lead antibiotic optimization. So my primary outcome measure was the % change in guideline congruence for acute otitis media antibiotic prescriptions that was attributable to the pharmacist's intervention. The way that this was measured was by assessing each prescription for guideline congruence as prescribed and then as dispensed. And any difference between the two we presumed was because of a pharmacist's actions. So we defined a guideline congruent prescription to be one where all 3 parameters of drug, dose, and duration of therapy matched guideline recommendations. The secondary outcomes involve breaking down these guideline congruence parameters to the choice of drug, the dose, and the duration of therapy individually. Okay, the results. The primary and secondary outcomes, so the % change in guideline congruence attributable to the pharmacist's intervention, I'll share in this, this upcoming table. So you can see in this pre-intervention part of the study, there was very little change that the pharmacist made on in terms of the guideline congruence of these prescriptions. There was still also very little change made in terms of the drug, the choice of the drug used to treat the prescription, the AOM. But where things get interesting is relating to the other parameters. So the dose, there was a significant improvement in guideline congruence attributed to the pharmacist's intervention there. And same thing with the duration of therapy. Now, overall, the pharmacists showed a 28% improvement in guideline congruence, and this was significant based on a two-tailed Fisher's exact test. Now I'll quickly go over this. There were some behavior changes that we did notice based on the intervention. So in the retrospective arm, there were very few clinical interventions made by pharmacists, and there was some discrepancies in terms of whether they were guideline congruent or not. Whereas in the prospective arm of the study, in the active intervention arm, there was a big significant improvement in the number of interventions made by pharmacists and the number of prescriptions that had a pharmacist intervention applied to them. And there were many individual recommendations made, although the acceptance rate of these interventions was modest at 65%. Another kind of side effect of the intervention was that documentation rates improved at the pharmacy. So they started off at 23% in the pre-intervention cohort, but this improved to 74% in the post-intervention cohort. Now, a quick discussion and conclusion. So in summary, the study intervention increased the rate of pharmacist clinical interventions, increased the guideline congruence of antibiotics dispensed for acute otitis media, and increased the documentation rates for antibiotic indications. Now, although their actions were highly guideline congruent, there was only moderate acceptance rates from patients and families, and most notably prescribers. So this study is one of very few to evaluate a program that leverages community pharmacists to improve outpatient antibiotic use, even though pharmacists are very well positioned and have the necessary knowledge and ability to optimize antibiotic use. And pharmacist-led prescription adaptation is a great mechanism available to leverage pharmacist expertise to improve antibiotic use in outpatients. Now, I just wanted to thank all of these special people who were involved in the project and acknowledge them, and I will take some time for questions.
Great, thank you so much, Catherine. I'll let folks type in questions if they have them to the chat box. Maybe from my perspective, just curious if this work has informed any of your own primary care practice or maybe how you approach certain conversations. I know that this was conducted in a community setting and you're working at an FHT with a great team, but curious what some of your takeaways were from a clinical or education perspective.
Yeah, good question. It's I don't see a ton of antibiotic stuff in my practice in a family health team, but I have just given my special interest in this. I've done a little bit of education with some of the nurse practitioners in my team, trying to help promote antimicrobial stewardship in primary care. But I wish that I had more of an opportunity in that front.
Yeah,
Are there any questions in the chat? I can't see.
Yeah, no problem. I don't see any yet. So if not, maybe I will let people follow up with Catherine if you do have any questions. But thank you again for your presentation. I think now we will transition into our breakout room. So as Lisa mentioned at the beginning of the session today, this is something kind of new that we're trying. We have a few breakout room facilitators. So I will just go ahead and split people up. I tried to set it up in advance based on some of the people that we had. So I'll just try and do a little bit of regrouping and get us set up. And then I'll try and pop into a few of the rooms as well. So just bear with me. I will just get us set up into different rooms and we'll go from there.
Like Lori and Connie and Suzanne did. I had a good time in my room too, so it's great to be able to have some smaller group conversation, which was exactly the intention, and we will repeat that at our next open summits in later in March and then in May. Good. Okay, thanks, Katrina. Glad we're getting some good feedback. So yeah, keep the chat coming. So, and really my job is just to say thank you to our speakers, to Kyle and to our research presenters to give us some really great thoughts and ideas to stimulate the rest of our day and the rest of our work really over time, and to let people know that there's more information on Open on the website, that link that's put here, our Facebook page, and then if you want to join the mailing list and you're not already on it, please feel free to email the open email that's listed below. And really just to say thank you. And if you'd like more information on Center for Practice Excellence as well, just please contact Annalise. We know that somehow you've connected with us because you've joined us today. So really, again, appreciating everyone's time, our speakers, our participants. It's wonderful to be part of this community and to be able to be back to have this kind of an exchange with all of you. And I look forward to our next event, which is on March 16th. And I encourage everyone to register ahead of time so that you can join us, and it will be online again. So thanks everyone, and hope everyone has a great rest of the day, and love seeing all the comments in the chat.